Welcome back to PowerPoint's Depression Part 3. This is video number 3. We are going to finish up this PowerPoint slide section where we are talking about different models of depression and inflammation. So the second hypothesis that we kind of talked about, well, the first one we talked about, but the second one here is the monoamine hypothesis. So remember here, then it's based on observations that drugs affecting monoamine levels are antidepressant. So specific emphasis is on serotonin and norepinephrine. And we have different types of pharmaceuticals. So we started with MAOIs, which inhibit monoamine metabolism. They work great, however, they don't have very good safety. We then have TCAs that inhibit monoamine reuptake. Again, not great safety factors. And then finally, what is most common today are SSRIs and SNRIs. So that's selective serotonin reuptake inhibitor and serotonin norepinephrine reuptake inhibitors. So these are the ones that are most common today. One only targets serotonin, the other targets both serotonin and norepinephrine. And then over here is just an example of a monoamine oxidase inhibitor, so one of the very first antidepressants ever used. So what's some observations and what's some limitations of this hypothesis? Well, first we see that deficits in serotonin are observed in depressed patients. We also saw that acute tryptophan depletion induces a rapid transient depression in healthy volunteers. So we can kind of cause these depressive symptoms by depleting tryptophan, which is the precursor to serotonin. And then finally, monoaminergic systems are involved in many aspects of mood. So we see that there's an extensive involvement in the limbic system specifically. Now, there are limitations to this hypothesis. So one is the time discrepancy between monoamine effects and therapeutic effects. So we're able to adjust the monoamine levels in the brain very quickly. However, the mood effects don't come for a very long time. So the monoamines, the chemicals, can normalize within hours or just a few days. Whereas the mood effects, we have to wait multiple weeks in order to see any kind of effect. So why is that? That's something we still need to figure out. And then there's also some drugs that decrease monoamines, but they actually work as antidepressants. So if a decrease of monoamines causes depression, then how is it that decreasing monoamines helps depression, all right? So two drugs in particular, we've got iprendol. This is a serotonin transporter 2 receptor. It's an antagonist, so it blocks that. So we're not getting the serotonin in the places we need. And then we've got tianpitine. This is a serotonin reuptake inhibitor. So the serotonin is not staying in the synapse as long as it would have. And yet, for some reason, this is helping with depressed patients, which is the opposite of what some of the traditional antidepressants do. So like SSRIs or MAOIs. And then cocaine and other amphetamines are very potent monoamine reuptake inhibitors. So they do what, again, these classic antidepressants do. And yet we don't see any antidepressant effects. So there's clearly something else going on. So what if we combine the inflammation theory with the monoamine theory? So here, then we know that peripheral inflammation activates the glia. So the microglia induces an expression of indoleamine 2,3-dioxygenase, or IDO. Okay, so And IDO actually catabolizes tryptophan in the quinurine pathway. Okay, so that's this pathway here. So here we've got L-tryptophan that normally goes to tryptophan hydrolase into serotonin. But here IDO also can work on L-tryptophan. So cytokines can then also induce catabolism of serotonin to 5-HIAA, or the breakdown of serotonin. So the cumulative result of IDO breaking down tryptophan so it can't be turned into serotonin, and the cytokines turning serotonin into 5-HIAA means that we have less serotonin in our system altogether. And so perhaps it's this extreme decrease of serotonin that is responsible for these depressive effects. Now, cytokines also increase the trafficking of serotonin transporters, and this will then increase the rate of serotonin clearance from the synapse. So yet again, we're getting even more depletion of the serotonin in the synapse. So it seems like inflammation is actually like increasing the monoamine deficiencies. So is it the lack of monoamines that's causing depression, or is it the inflammation causing the lack of monoamines causing depression? Now, the last hypothesis, again, one we didn't really have a whole day on, is the neurogenesis hypothesis. Again, this hypothesis is really just saying that impaired neurogenesis leads to development of depressive symptoms. So there's certain stressors that are capable of triggering depression, and this actually inhibits neurogenesis in animal models. So it leads to like a damaged brain, pretty much, because you can't the cells that are naturally dying are normally, there's new cells coming up to replace them. But when there's extreme stressors that triggers depression, then we don't get the neurogenesis of new neurons, meaning the brain isn't able to repair itself when an old cell dies. Now, we do see that we get an increase in neurogenesis again during antidepressant treatment. So it suggests that neurogenesis does play a role in depression. And this would actually, the time required for this neurogenesis may explain the therapeutic delay. It may explain why it takes 2 to 3 weeks to see any mood effects of taking antidepressants, because it takes a while for neurogenesis to occur. There are behavioral responses to antidepressants as well, that are diminished by blocking neurogenesis. Now, there are multiple limitations to the neurogenesis hypothesis as well. For instance, some regions of the brain are highly involved in depression, actually don't show signs of adult neurogenesis. So, for example, the prefrontal cortex, it's highly involved in emotional and cognitive changes in depression, but we don't naturally see large amounts of neurogenesis in adults. So if there's not supposed to be neurogenesis, then it doesn't make sense that a lack of neurogenesis would cause depression. Now, neurogenesis is well demonstrated in animal models. So depressive behaviors in an animal model are at best a proxy, because again, we can't ask them how are they feeling, that kind of thing. So it's very difficult to always model a behavior in an animal. It's also very difficult to examine a depressed human brain. You can't just take it out and look at it. You have to do fMRIs and that kind of thing. But a lot of times for someone that's depressed, especially severely depressed, then it can be very hard for them to go and participate in a study. So those with severe depression are less likely to participate in these studies, which means we can't examine their brains. It also limits the generalizability of the results. So because the animal models are at best a proxy, we can't fully generalize the results. And then again, because we're only dealing with in human studies, we tend to only have people with mild to medium symptoms. Again, we can't generalize those results to those with severe depression. Now, how could inflammation play a role in neurogenesis then? Well, elevated cytokine levels we know is connected with inflammation. But this also tends to decrease the trophic support to neurons, which means we get a reduced neurogenesis. So an increased cytokine level naturally decreases neurogenesis. We also see that it increases the oxidative stress, which means less oxygen for neurogenesis. It also then disrupts the neuron-glia interactions, and we really need those interactions for the neurogenesis and for those new cells to know, well, one, where to go, and also what type of cell it needs to become. Using animal studies, we have been able to show that stress or cytokine administration decreases social function. And this correlates with decreased neurogenesis. By administration of an IL-1 receptor antagonist, it actually blocks both effects. So it blocks the effects we see with the social function and with the neurogenesis. Now, products of IDO, remember that was here. So when IDO is what's breaking down tryptophan, here are the products. So that's huinerine and quinolinic acid. Those are both geotoxic and neurotoxic. So they can damage those astrocytes, and that reduces the regulation of glutamate. And quinolinic acid is an NMDA receptor agonist. So it can actually exacerbate those glutamatergic excitotoxicity. So during inflammation, then what we see is that it's not just affecting the monoamines, but now it's also affecting glutamate and GABA. Now, we also know, of course, that those microglia are very involved in inflammation, but they also seem to play a role in depression itself. So these pathological stress or some sort of peripheral inflammation can activate that central nervous system resident microglia. And this will then increase the secretion of cytokines, because remember, it's the microglia that produce cytokines. And the activation then results in excessive synaptic pruning. So we'll actually remove some of those synapses, and with less synapses for our monoamines to act on, then we're getting even less activation with those monoamines. So we're getting even less serotonin and even less norepinephrine. It also inhibits neurogenesis. So we tend to not see neurogenesis when microglia are around as much. And then the collective effects may actually contribute to these pathological cell death and result in some sort of behavioral cognitive dysfunction. So not only are we preventing new cells, but we're causing old cell death. Now, what if we can then do some sort of anti-inflammatory treatment? Will that help depression? Because it definitely looks like inflammation seems to play a role. So there's been multiple studies that look at this, and anti-inflammatory treatments in a medical comorbidity of depression have seen antidepressant effects. So before we talked about how we could administer TNF-alpha in healthy patients to kind of cause depression. Well, now we can actually give them an anti-TNF-alpha treatment that's used in psoriasis, actually lowers a depression score independent of its effects on psoriasis severity. We also see anti-inflammatory treatments on arthritis also help to improve mood symptoms. Now, a lot of these treatments are done on those, so like this one was done on people with psoriasis, and this one was done on people with arthritis. So it wasn't done in a study where we caused depression with TNF and then gave an anti-TNF to see if it would normalize. So these are in patients that have a medical condition with a comorbidity of depression. Looking at retroactive studies, then they show depressed patients co-administering acetylsalicylic acid or aspirin at higher rates of remission. Okay, so discontinuation of aspirin or ASA correlated with elevated mood scores. So when they stopped taking aspirin, their mood increased. Okay, and that's because aspirin, helps with pain and stuff. And bipolar patients taking ASA had decreased incidence of medication changes, so they didn't have to change their antidepressants as much because it was a surrogate marker for their condition. And then finally, some clinical trials have demonstrated efficacy of celecoxib, which is a selective COX-2 inhibitor, as well as minocycline, which is an antibiotic that has anti-inflammatory effects, as effective adjunctive therapeutics with antidepressant therapy. So they're saying taking anti-inflammatory drugs by themselves don't really work as antidepressants, but when you pair it with, say, therapy, some sort of antidepressant therapy, they do help. They're like an additive benefit. And then finally, there are, of course, observations and limitations. Let's just go over the limitations. So inflammation is not observed in all depressed patients. Only some show it. Some patients actually show decreased cytokines. So again, just like all the other hypotheses, we're not getting the full story. Monoamine oxidase inhibitors, or MAOIs, are poor anti-inflammatories. So why are these antidepressants that aren't anti-inflammatory still having antidepressant effects if only inflammation hypothesis is right? So again, it seems like it's a combination of multiple hypotheses that are correct. Another limitation is that a lot of this work is derived from animal model. Now, animal models can be great. However, you always have to consider the generalizability of these models. So that's it for depression part 3. There is one more small hypothesis we're going to talk about, and then we'll move into research models of depression next week. Have a great weekend.